Thank you, Beth, Tom, for your leadership. Dr. Kinney, Dr. Sharma always has been a big supporter of nurses, as you could see with this Nurse Tech Symposium. I thank you, ladies and gentlemen, for your time today. So I'm here to talk to you today about STEMI and how we can utilize artificial intelligence so we can better coordinate and provide faster, smarter care. I don't have any relevant financial disclosures for this presentation. So my objectives between now and your coffee break is to describe STEMI to you guys. The definition, what are the physiological impacts of STEMI? I'm going to explain what the importance is of timely reperfusion and the impact that it has on outcomes. We have a homebrewed care coordination app here at Mount Sinai called STEMI Cath-Aid, and I'm just going to show you briefly about its functionality. And then we're going to take a look down the road and maybe more of like the Instagram commercial about what's the future of AI with STEMI, faster, smarter coordination. So as a quick review, what is a STEMI? It's a time-sensitive medical emergency. It often manifests with sudden onset chest pain. And this chest pain occurs because there's a vulnerable plaque rupture in the coronary artery, which activates the clotting cascade. And that clotting cascade causes a completely occlusive thrombus in the coronary artery. That occlusive thrombus causes transmural myocardial ischemia through all three layers of the heart muscle, the endocardium, myocardium, and epicardium. And we can see this ischemic changes very quickly on EKG. As all you guys know, in the cath lab, when we inflate a balloon, we sometimes see ST elevations just from the ischemia that we induce during the procedure. So really quick, on an angiogram, you can see that the LED is missing due to that occlusive thrombus. So the two major focuses in the care of the STEMI patient are rapid diagnosis. We need to know that this patient's having a STEMI. This is why we have this metric, door to EKG. We need to have that EKG done in 10 minutes. And then the second thing is reperfusion therapy. For those hospitals that have a cath lab, we like to bring the patients into the cath lab with a goal of the first medical contact to the first device of 90 minutes. And for those patients that need to be transferred to a cath lab that doesn't have a cath lab is 120 minutes. Hospitals in the rural area that don't have access to this, their only choice is fibrinolytics for reperfusion therapy. Delays, they're really bad. They increase mortality, and particularly worse with cardiogenic shock. And just to put a figure in this most recent 2025 ACC-AHA guideline that they quoted, was that mortality in 1 year increases by 7.5% with a 30-minute delay, which is a lot. Because of this, we have really stringent registry time metrics with AHA and also an ACC. So looking at these clinical practice guidelines that came out just earlier this year and actually was printed on Tuesday, it was class 1 recommendation to bring the patients to the cath lab for primary PCI with the goal of doing it within less than 90 minutes to improve survival. That's how serious we're taking this. So as you all know, the big rush and the hectic commotion around a STEMI patient is that we have these very busy algorithms. And how do we remember where the next steps are in the algorithm, and how do we do that safely? Particularly when all the recommendations are to bring this patient quickly to the cath lab. These patients, as you guys all know, have very high acuity. They're oftentimes very unstable, and we're rapidly transitioning them through the care system, whether it's EMS, bringing them to the ED, and then up to the cath lab, oftentimes in less than a movie. So how do we do this safely? Particularly when we have the push from AHA to completely bypass the ED, as much as I love our ED colleagues, but they may actually like this as well. But knowing that clinical deterioration, cardiogenic shock, and cardiac arrest is always something looming in the back of their mind, we need to be able to all stay together so that we can work together to save these patients. AHA takes this very seriously and wants us to build a system of care with timely management, using a single call approach. And for those hospitals that participate, we have to actually send our performance metrics to this hospital, these registries for evaluation. Late last year, SKY came out with an expert consensus on the statement on the management of patients with STEMI. And basically what they were saying is that a single call or telephone call activation to the STEMI team is only as good as the method that you use to activate, whether it's a very organized hospital operator or utilizing really novel applications, application-based systems to coordinate the entire care team. So here at Mount Sinai, now I will say the Mount Sinai Health System, we are using the STEMI Cath-Aid. And the STEMI cath aid was born here in this hospital. It was developed by the cath lab team in coordination with ED team members, and it's a multidisciplinary care coordination application. We use it both locally and interfacility for transfer. We have the EKG of this patient immediately accessible to the entire care team. For those patients that require EMS, we can get the GPS tracking so that we're all able to be prepared to take care of this patient. And gone are the days of using WhatsApp and thinking about what will hospital IT do if I'm sharing protected information unsecurely. We're totally HIPAA secured. Currently, we're live at Mount Sinai Queens for local use, Queens to Mount Sinai Hospital for transfer, and West to Morningside for transfer, with lots of discussion about using it locally at Mount Sinai Morningside, and soon we'll be looking at expanding this at Mount Sinai South Nassau. So let's quickly just take a look at how the STEMI app works in the transfers from Mount Sinai Queens to Mount Sinai main campus. This is a patient that showed up to the ED as a walk-in with chest pain and shortness of breath at 3 a.m. EKG was done very quickly, showing anterior ST elevations and reciprocal T-wave inversions in inferior and lateral leads. And this patient does have risk factors for CED, hypertension and smoking. Now the ED physician will suspect STEMI, they'll raise a case, and that alert will go directly to the interventional cardiologist that's on call with all the information that they need as a background before they have a very important phone call with the attending to decide whether or not this patient is appropriate for cath. As this is happening, the transfer center is simultaneously dispatching an ambulance to save time. So even before we have a decision whether this is a go or not, ambulance is moving. Once this case is accepted to bring to the cath lab, there's a single one-press button that notifies the entire clinical team with a critical alert. No calling, no paging, everyone gets the notification. Now that everyone's in the loop, the vital signs are shared, shock screening is done, what medications are given can be communicated to the team, and now we have an open communication between the referring teams, accepting teams, transfer center, and the CICU. GPS tracking of the patient allows the ED to know when the ambulance is coming, and for the cath lab to know when the patient has arrived. So this patient was having an anterior STEMI at Mount Sinai Queens. We can see that his LAD was completely occlusive, and we put one stent in his mid-LAD. So just looking at the transfer times, the Mount Sinai Queens door in, door out time, which is a goal of 45 minutes, was done in 42 minutes with the application. The actual driving time was 24 minutes. And the arrival time to the cath lab device was 16 minutes because we're all ready and waiting. So that's a door-to-device time of 82 minutes, nearly 40 minutes under the benchmark of 120 minutes. Earlier today, Dr. Sharma was very proud about all the accolades we have at Mount Sinai, but this was one that we kind of put our head down in shame, where before the app we were not meeting the AHA threshold of just over 70%, where we needed to make 75%. This is where this quality project was born, and after we had implemented the app, all our transfers since we went live in 2021 has reached 100% of the 120-minute metric. Our door in, door out time went down from 68 minutes down to 52, the average door in, door out time. And nearly 30 minutes was chopped off the door-to-device time in these transfer patients. So real significant improvements in performance. Because we're working faster, that means our patients are doing better. I talked about how the outcomes, the delays increases mortality. And at Mount Sinai, our STEMI mortality is 0.3% for in-hospital death. So what's the future of STEMI? What's next? You know, right now we're using WhatsApp. Before we were using WhatsApp, we had pagers and fax machines to get this EKG transmitted. We took the first step to using a STEMI app as a care coordination tool. But I think the future is really to utilize and take advantage of artificial intelligence. And I think I want to propose adding another member to the interdisciplinary team, which is Sophia. Sophia, you're going to hear from Dr. Kinney and Grace. They're going to talk about why Sophia is so efficient as an artificial intelligence tool in communication. And you'll see the strength of how Sophia can really summarize conversations. So when we have a patient that's having a STEMI, we oftentimes will have the attending phone call with the transfer center listening in. And those of you who do take STEMI call all know that you have no idea what happens on that telephone call. So now we plan on integrating Sophia into that phone call, and then you can see now, as the phone call is happening, Sophia is building the AI call summary of that telephone call. In addition, other AI tools utilizing the EHR in Epic, where we can actually scrape the relevant information so that the entire care team is all on the same page. We know how to properly take care of this patient. Remember, these patients are moving rapidly through the system, and like I said, this is less than a movie that we need to take care of them. So to wrap up, STEMI is a time-sensitive medical emergency. It's associated with transmural ischemia. Rapid diagnosis and treatment improve outcomes. We want to utilize healthcare technology for workflow optimization. That was a very busy algorithm. We want to be able to coordinate all together as a team. And artificial intelligence will augment the STEMI team to deliver better care. Before I finish today, I want to thank everyone throughout the Mount Sinai Health System. I've been meeting with all the STEMI center sites throughout the system, and I'm really proud of the hard work that everyone does here. Here at Mount Sinai main campus, we've been AHA Gold Plus, and we got it again for last year, which is a very important award to us. And it's also recognized by the Joint Commission in the Comprehensive Cardiac Center. And I really hope to see our colleagues, Mount Sinai Morningside, Mount Sinai Queens, and hopefully Mount Sinai Nassau also joining the ranks, and we're here to support them. Thank you, everybody, for your time.